Hello, my name is Stephen Wexler and I'm the Chief Medical Officer of NES. And today we're going to be discussing critical care documentation. The purpose of today's lecture is not so much to focus on the details of documentation, but really to focus on the clinical scenarios that should be considered critical care. It's my belief, after reviewing documentation over several years, that emergency physicians are performing critical care every day and just do not realize it because this is the work that we do, it's the things that we're accustomed to doing, and so we don't think that we should be getting credit for it, when in fact the main work that we do every day really deserves some version of critical care. Simple things, background coding, don't expect you to memorize this. 99291 in the coding world refers to 31 to 74 minutes of critical care. We have to have at least 30 or greater minutes to qualify for critical care, so that's where we use the 31 minutes. 99292 refers to anything greater than the 74 minutes by 30-minute intervals. You don't need to remember that. The coders will do it for you, but again, it just gives you a little background information. So what is included in critical care? Obviously time, right? Greater than 31 minutes. So what is included in the time? First of all, some of it is the time that you're at the bedside, examining the patient, re-evaluating the patient, but then there's also the time spent where you're titrating medicines. So if you have, let's say, a labetalol drip going and you're re-evaluating the blood pressure to the patient, and you go in and see how the perfusion of the patient is, see if the patient is mentating, making sure that they're neurologically non-focal, that's all time reassessing. In addition, not only are we titrating medicines, but we're titrating ventilator settings, we're titrating CPAP, we may be even titrating fluids, and that all really is included in critical care. In addition, not only is the time at the bedside included, but the time spent speaking to consultants, speaking to EMS if they're going to transfer, speaking to the helicopter service that might be transferring the patient, in addition to just discussing with the family and the patient as well. When you're referring a patient, the time that we use to speak to the transferring center and or the receiving doctors or specialists on the other side is all included in critical care. And so you can see within a few moments, or what seems like a few moments, we easily accumulate 30 minutes of critical care time on these patients. What is not included in critical care are procedures. So if you're doing an intubation, if you're doing a central line, if you're doing a limb-saving procedure, let's say a dislocation with no pulses, the time that's spent doing the reductions, the procedures, the intubations, etc., is not included in time for critical care. That time is just included in the documentation of the procedure and getting credit for the procedure itself. So, little background. In general, hospitals that can achieve a 10% admission rate, and we say admission rate, but really what we're including in admission rate is also transfers. So if your combination of your hospital in admission and transfers is 10%, then you should be achieving a minimum of 3 to 4% critical care. And that's pretty much a national standard. For NES, we have hospitals that are doing 15 to 20 to 25% critical care and only documenting barely 2.5% critical care. And so you can understand really the big gap that we have as a company. So why do we have such a disconnect? Well, first, we, the physicians, take for granted all the work that we do. And again, we're going to get to now the clinical scenarios that we do every day and would assume is not critical care when in fact it is. Second, we all are on electronic medical records, and those medical records have varying degrees of difficulty in documenting. And so using the electronic medical record sometimes prevents us from getting to critical care documentation because it's so onerous or slow to use. And then lastly, documentation is always the first thing to go because patient care is the most important thing that we do, and we need to be at the side of the patients. And so if we get an influx or it's particularly busy or we have a particularly sick patient, then the documentation seems to fall off. All right, getting to clinical scenarios. I group them not in any particular order or not in any particular importance, just so you understand where I'm going in the lecture. So let's take something simple like atrial fibrillation, something we deal with every day. If you are giving IV pushes of medicine, cortisone, low pressor, labetalol, any esmolol, and adjusting, not only giving pushes and reevaluating, but giving pushes and or setting up drips, that is all included in critical care. Our sick congestive heart failure patients that come in, and you're giving them maybe initially sublingual nitro, maybe giving them even nitro IV pushes, or setting up an IV drip, potentially getting CPAP, or even prepping for intubation or doing intubation, that is all critical care patients. And of course, our ST elevation patients are critical care as well. Now, some of you are at cath lab centers where you're doing, STEMI cases and you have STEMI protocols. And for many of you, the patients are coming in and within 15, 20 minutes, they're leaving your department because you're a well-oiled machine and they're going to the cath lab to get their arteries opened. And you say, oh, well, 15, 20 minutes doesn't count for anything because it's not enough time, right? It doesn't trigger that 31 minutes. But if family's left behind, or if you have to go speak to the family in the family room, or the fellow comes down to discuss with you, all that time that you spend talking to them, even though the patient is not necessarily at the bedside, they may be being wheeled off to the cath lab, that is all included. And most of the time, you can get to your 31 minutes of critical care. I included hypertensive emergencies and urgencies. Again, if you're at the bedside, giving pushes of medicine and then reevaluating the patient, that's all included in critical care. Certainly if they're on a drip and you're adjusting the drips and titrating it to their blood pressure, again, critical care. Then we have our aortic dissection patients and our aortic aneurysm. I think those are obvious critical care patients. But again, just a reminder, you need to be documenting on those patients. Under pulmonary, acute asthma exacerbation, especially in kids, right? So you're at the bedside, you're nervous because you have like a 5-year-old, you're wondering if you have to give epi, you may be giving continuous nebs, you've given your steroids, you're giving magnesium, some of you have Heliox that you're given, and you're at the bedside, maybe even while you're preparing for an airway. That is all critical care time. And I use children as an example because a subset of those kids in 3 or 4 hours may actually go home. So you get over their acute phase of their illness, maybe that takes 30 minutes of reevaluation, maybe 40 minutes, and then you're going back in to reevaluate them, and then miraculously you've broken their asthma exacerbation, and then you're watching them for a couple hours later because guess what? You think you can go home. Even on that discharged patient, that's still critical care. COPD patients, same thing. They're usually not going home, but some of them you're getting BiPAP ready or you're putting them on BiPAP, you're prepping an intubation while you're doing your interventions, all critical care time. And almost anybody that requires some form of either invasive mechanical ventilation or non-invasive mechanical ventilation, all should be put and all should be documented with critical care. And remember, as an aside, that your first diagnosis actually should be respiratory failure, and then asthma exacerbation or COPD exacerbation, etc. Our PE cases, especially the ones that are hypoxic and or tachycardic, are all critical care. patients that have pneumothoraces, hemothorax, empyemas, especially if they have abnormal vitals, pulse, blood pressure, hypoxia, all critical care cases. All right, let's move to neurology. Obviously, we have our stroke alerts. Some of us are stroke centers. Some of us are using telestroke. Any case where you're calling a stroke alert, you're using your stroke team, you're using telestroke or teleneurology, that is all critical care. Your cerebral bleeds, obviously, just like your stroke cases, you may be adjusting blood pressures, using medicines to control the hypertension of these illnesses, all deserve critical care. Our spinal cord injuries are all critical care, speaking to the neurosurgeon, speaking to the neurologist, getting ready to transfer patients, all part of your critical care. Even your acute ALS patients or acute myasthenia patients should be included in your neurologic critical care cases. Sepsis. Severe sepsis and septic shock. Most people who trigger your sepsis protocol and then have a positive lactate greater than 2 should all be documented critical care. Obviously, in your septic shock patients where you're putting in central lines, using Levofed, all critical care. But even in your severe sepsis, where you may not be getting to pressure support, but you're doing your 30 mLs per kilogram of fluid resuscitation, you're rechecking them for perfusion and reassessing the patients and going back to determine, or you now have a positive lactate that's greater than 2, and now you've ordered a second lactate, that is all critical care and the credit should be given to you for doing that work and documented in your critical care diagnosis. Sorry. GI. Obviously, GI hemorrhage with or without hypotension, especially when you're dealing with consultants, your GI specialists, your hospitalists. If you're concerned about airway and your upper GI bleed, all critical care. Your perforated bowel, that's peritoneal, tachycardic, certainly hypotensive, critical care. Has to go to the OR, so you're speaking to anesthesia, you're speaking to the surgeon, maybe some consultants. You're trying to get them hemodynamically stable. Before they go to the OR, you're giving antibiotics. Again, all part of your critical care. I say sick appendicitis. Again, febrile, tachycardic. Most of our appendicitis aren't in septic shock, but if their blood pressure is 100 or even 110 and they're tachycardic, and you're resuscitating them with fluids and giving antibiotics, all part of your critical care. Ascending cholangitis, whether or not they're septic or not, again, should be critical care. Some of them you're speaking to GI for potential ERCP, some you're speaking to your surgeons, you're giving varied antibiotics, you're fluid resuscitating them. Again, cases that we see every day, part of your critical care documentation. Lastly, I talked about bowel obstruction and or volvulus. Certainly if they have abnormal vital signs, certainly if they're dry, if they have multi-organ system failure, so you've had your SBO that comes in or your volvulus that's been vomiting, and now they have an element of renal insufficiency, and so you're fluid resuscitating them and then maybe even reevaluating what their kidney function is, that is all part of your critical care. In children, your sick pyloric stenosis, the baby comes in floppy because they're so dehydrated from vomiting, definitely critical care. Trauma. Most trauma codes should be considered. Obviously, we've all been to lower level trauma codes where we go and we evaluate and they're not getting imaging and maybe we're not speaking to consultants. Probably not going to get away on those with critical care, but any ones that are involving trauma team, orthopedics, procedures obviously, intubations, central lines, chest tubes, all part of critical care. Almost any case that has arterial bleeding, even if it's not life-threatening, but maybe limb-threatening, that is part of your critical care. Again, we spoke about pneumothorax or hemothorax. Certainly in the setting of trauma would be part of critical care. Ophthalmology, any acute eye trauma, especially if it threatens the globe in its entirety, and you're dealing with consultants and you're elevating the head of the bed and you're shielding them and you're keeping their pressures down, certainly part of critical care. Acute angle glaucoma, again, adjusting medicines, speaking to consultants, possibly arranging for transfer, critical care. And then we have our hemorrhages, vitreous hemorrhage, retinal artery hemorrhage, again, dealing with life-saving procedures in acute cases, dealing with consultants and transfer, part of your critical care. Retinal artery occlusion should be considered like a stroke, and you only have a limited amount of time which to save the eye. Needless to say, should be documented. Hypotension. Basically, anybody who's dehydrated and hypotensive should have the appropriate documentation. Spinal cord injuries resulting in hypotension, proper documentation. And then, of course, adrenal crisis. Those patients that come in, you think they're probably septic, and then finally you're figuring out that they're in adrenal crisis, you're giving fluids and steroids, all part of proper documentation towards critical care. A lot of our endocrine cases, DKA, your hyperosmolar non-ketotic patient, as you're giving fluids, you're reassessing, you're checking their sugar, you're adjusting insulin drips, you're giving repeated doses of insulin. Part of the necessary documentation, reassessment towards critical care. We talked about your adrenal crisis, any electrolyte abnormality that results in EKG changes. So hypocalcemia, hypokalemia, hyperkalemia, magnesemia, hypomagnesemia should all be, as you're adjusting those electrolytes, part of your critical care documentation. Obviously, any patient that needs urgent dialysis, either for hyperkalemia or for fluid overload, as you're making those arrangements, needs the proper documentation towards critical care. I apologize. In summary, emergency physicians do critical care every day. It is important that we recognize it, document it, and really take credit for all the hard work that we do. Thank you for your time, and we'll see you soon.